Good afternoon, everyone. At the outset, I would like to thank the critical care team headed by Dr. Ramna of this wonderful, hospital asset for their entire region, Yashoda Hospital, High-Tech City. Proud to be part of this deliberation today. And this concept is really nice, critical care case-based discussion. So I was amazed by the fact that from the morning different specialists is coming and putting before the case scenarios and how we can coordinate, collaborate together to optimize the outcomes in these scenarios. Again, beyond academics, virtual to actual post-COVID pandemic is more important because this gives us an opportunity to network and meet and greet with our colleagues. So when it comes to hematology in critical care, it is both ways. We are sister concerns. Hematology, hemato-oncology is also a subspecialty, I feel, of a critical care medicine, and either it can be hematology patients going into critical care, mostly the neutropenic sepsis and all organ dysfunctions, both in hemato-oncology, benign hematology and bone marrow transplant, and also a lot of critical care patients have many hematological issues, commonly thrombocytopenia, the commonest one, but not just isolated thrombocytopenia, but thrombocytopenia underlying various catastrophic conditions like DIC, coagulopathies, thrombotic microangiopathies, so on and so forth, apart from the cytopenia. So I'll start with the critical care patients having hematological issues. So thrombocytopenia being the commonest one, it's the most common hematology consult across ICU, mostly seen in surgical or polytrauma patients, and generally associated overall compared to the one of the prognostic markers, thrombocytopenia per se is associated with higher mortality, morbidity in the hospitalized patients in the ICU. So you can see through the various literatures, mortality increased by 4 to 6 times if thrombocytopenia is sustained more than 4 days, mostly the moderate to severe thrombocytopenia, and it's a marker of underlying serious illness independent of the bleeding event. So thrombocytopenia in ICU setting can be categorized into 2 different types. Somebody has a bleeding profile, some patients have a thrombotic profile. So management totally changes depending upon the patient's clinical phenotype, and of course the clinical phenotype depends upon the underlying etiologies like bleeding, mostly the ITPs, the immune thrombocytopenias, drug-induced thrombocytopenias, marrow failure associated thrombocytopenias, whereas those associated with thrombosis are more catastrophic like microangiopathic hemolytic anemia, heat, and various other conditions, the commonest in the ICU setting being DIC of sepsis. So I'll kickstart with my cases. This is a renowned neurosurgeon from Kadapa. This was the case I had seen at Yashoda Secunderabad about 7 years back. So he has swine flu and he has severe ARDS and he was on ECMO. The reason hematologist was called in was he was having progressive thrombocytopenia with a normal platelet count on admission of 1.5 lakhs and another platelet count of 30,000. Also on examination when I was evaluating this patient, this neurosurgeon, he has superficial skin necrosis on the right thigh at the site of previous injections. So if you look at his hemogram, he has hemoglobin moderately low, WBC normal, WBC differential normal, the platelet count is 30,000. As a rule, any patient presenting with thrombocytopenia, reflexly you should send LDH because it has various consequences. I'll come across to that later. So the renal profile was normal, LDH was quite high, more than 6 times higher, and the coagulation parameters PT, APTT was normal. So diagnosis, any clues? So yes, so this was a case of heparin-induced thrombocytopenia. I forgot to give the timeline of this thrombocytopenia. It started on 6th day being on ECMO. So this was a case of HIT. We all know the pathogenesis of HIT. It's because of the antiplatelet antibodies, anti-PF4 platelet factor 4 antibodies, mostly surgical patients, but mostly more in cardiovascular surgeries, but nowadays trauma and other surgical and medical patients are also we are seeing with HIT. So platelet activation leading to thrombosis is the reason, and then this is the typical presentation. You can see a patient who has already a previous heparin exposure, that classical timeline of 5 to 12 days will not happen. It can start right on the day of heparin infusion initiation, whereas the classical typical onset is 4 to 14 days, and sometimes the delayed onset hit can be seen when the patient is off heparin. Still the patient due to these antibodies can develop hit. So again, this is the nadir platelet count. All the patients should have more than 50% decline in the platelet count, or again, this is not just thrombocytopenia, but sometimes isolated thrombosis, skin necrosis, and systemic allergic reaction itself can be the presenting feature of HIT. So this is again the HIT antibodies, and this is a classical 40 score. Most of the times ICU we are fond of these scores and algorithms, and most of the times our clinical decisions evolve around these score based predictors. So again, the thrombocytopenia, timing of fall, thrombosis or other sequelae, and ruling out other causes. You can see the important points here, 2 points for thrombocytopenia and the timing, and 1 point for other possible causes of thrombocytopenia, and if there is no thrombosis, other sequelae, there is a 0 score. So score 0 to 3 HIT is unlikely, but score more than 4 HIT is most likely. You should stop heparin, start alternate anticoagulation, otherwise these patients can have catastrophic consequences. The treatment revolves around stopping heparin and trying non-heparin anticoagulants like lepuridine, argatroban, danaproid, fendaparin, and newer anticoagulants are also being offered. So anticoagulation has to be continued for at least 2 to 3 months if there is no thrombotic event, and 3 to 6 months if there is a thrombotic event. So again, these are the various heparin preparations available. So you can see the pentasaccharides are the least immunogenic. Again, direct thrombin inhibitors are also coming into picture. There are case reports of these NOACs and DOACs like darbegatran, rivaroxaban, apixaban being equally effective in HIT. So fondaparinux is something which commonly we use in patients with HIT. So compared to historical controls with HIT antibody positive, these have a relatively better efficacy with prompt platelet recovery. This is my second case. This is a 49-year young lady, a known lupus, hypertension, and has a prior stroke, admitted with cellulitis and possible UTI. She was started on appropriate IV antibiotics, and in view of her comorbidities, she was also started on heparin for her DVT prophylaxis because she was hospitalized quite long in the hospital setting. So on the 5th hospital day, she starts developing thrombocytopenia. At this point of time, the platelet count is 66,000. So how should we approach this patient? Again, as per the previous case, the HIT is a clinical probability. So HIT score is intermediate. So we stopped heparin, but and the heparin PF4 antibody was negative, and platelet continued to decline. Now, how will you approach these patients? Remember, this lady has sepsis, UTI, and she is continuously spiking. So PT-APTT was done, which was higher. So possibly this lady is sipping into DIC. Again, depending upon the underlying etiology here, like sepsis, mostly it is hemorrhagic tendency. So PT-APTT was high, and then this is acute DIC because sepsis underlying. So again, a spot polytrauma patients with pancytopenia. Any clues? Same DIC, right? So again, you can see this polytrauma patient has thoracotomy because of hemothorax, and you can see continuous oozing to the extent that the bed linens are completely soaked with blood, subnormal temperature. So pancytopenia, this picture itself is very much telling that the underlying cause is DIC. So again, the DIC mechanisms are the various etiologies leading to coagulation, systemic coagulation, cascade activation, and this works both ways: intravascular disseminated microthromboid deposition, and then consumptive coagulopathy leading to bleeding. So bleeding is 5 to 12% of the patients, thrombosis is 10 to 15% of the patients, but more so in the sepsis 40%. So for DIC, there is no single test sufficiently accurate to establish or reject the diagnosis. It's the combination of the features, clinical features, which can help us coming to a conclusion. So this is another lady which we had seen at Yashoda Somajuguda about 4 years back. She is 32-year lady, primary LSCS for arrest of descent outside. So she was shifted to Yashoda. Intra-op they found placenta adherent, removed manually. She was having atonic uterus despite continued uterotonics. So oxytocin, ergometrin, carboplast was sequentially given. Still she continued to have profuse PPH. So uterine compression sutures, bilateral uterine ovarian vessel ligation was done, and eventually the blood loss continued beyond 2 liters, and she was just managed with PRBC transfusions and intravascular volume replacement. So to the extent she continued to bleed profusely, so they ended up with subtotal hysterectomy, and this was the time hematologist was called in. So we went and looking at this uncontrolled PPH, a single dose of Novo 7 60 mics per kg, initial dose halted the bleeding by 50%, second dose complete stoppage of PPH. So again, this case illustrates early hematology referral could have saved all these surgical interventions. So for us hematologists, death is coming, and involvement of the multidisciplinary teams early can definitely lead to more rewarding outcomes. Again, we are all movie lovers. This was a movie. You all know this lady dies of PPH, Rani Mukherjee, but she's dying, but still she is so stable. So actually in practice in ICU, these patients don't give us so much of time. So little proactive steps and early multidisciplinary approach can really safeguard these lives. Again, as I mentioned you earlier, DIC has 2 bullets. It's a double-edged sword, systemic coagulopathy as well as conjunctive coagulopathy leading to a profuse bleeding manifestation. So again, thrombotic microangiopathy leading to organ damage, and hemorrhage is the hallmark of DIC. So again, depending upon the underlying etiology, the phenotype can dominate other bleeding or thrombotic. So signs, symptoms we all know: bleeding, skin oozing, shock, and the subsequently multi-organ failure. So important thing to differentiate DIC from other similar mimickers, thrombotic microangiopathies, is abnormal coagulation parameters and hypofibrinogenemia along with thrombocytopenia. So of course this is a DIC score which we all are well versed with in using the critical care setup. So based on the 5 factors you calculate a score. If the score is more than 5, it is compatible with DIC, more aggressive management of the underlying etiology. If the score is less than 5, non-diagnostic. Again, non-diagnostic doesn't rule out completely DIC. You keep on repeating the assays, repeating the parameters. Sometimes the early DIC may not fit into the complete DIC criteria. So again, the treatment, the essential rules underlies the treatment of underlying cause, and depending upon the phenotype, clinical phenotype, bleeding, aggressive transfusion support, and thrombotic aggressive anticoagulation, along with the measures to eradicate the underlying etiology. So other causes of thrombocytopenia in ICU, commonly we see drug-induced thrombocytopenias. Again, median type 2 onset is 14 days, and once you stop the drug, many a times the intensivists are very apprehensive why the platelet count is not recovering after stopping the drugs. The median time to recovery is 7 days. So these are the different drugs. Any drug on earth can cause thrombocytopenia practically if you open up your up-to-date or the dictionary of drug-induced thrombocytopenias, but certain drugs are more temporally associated with thrombocytopenia. So which drug most likely causing thrombocytopenia in ICU setup? When the patient is on multiple drugs, it is very difficult. So close temporal association and withdrawing one by one probably is the key. So these are other causes of thrombocytopenia in ICU. Thrombotic microangiopathy is APLA in autoimmune disorder. So another case, 38-year lady with history of migraine headache presenting to our ER with worsening headache for almost 2 days prior to her visit in ER. So barring this migraine, she has no other medical illness. She was on these drugs, ibuprofen, sumatriptan, meclizine for migraine. While she was waiting in the ER, she has developed slurring of speech, and eventually she ended up having a seizure. So this was her hemogram. You can see thrombocytopenia, platelet 26,000, reticulocytosis 8.8, creat 1.6, INR marginally high, CT non-contrast CT brain was normal. So I'm sure you will agree with me, this clinical association, clinical presentation of this lady is itself telling about the possible thrombotic microangiopathy. So we did LDH. LDH was very high, haptoglobin took time to come, but peripheral smear, schistocytes, high LDH, AKI, seizures, and thrombocytopenia was consistent with the DIC, so she was started. So incidence is 4 per million in cases, mostly young women, and if untreated, the mortality can be very, very high, more than 90%. Treatment with plasma exchange, which is gold standard for the TTP, the mortality can be brought down to as less as 5 to 10%. Again, very important, the classical penta described in Harrison's is hardly seen in clinical practice. Most of the time, these young girls and young females present with isolated thrombocytopenia, but if you miss the diagnosis and delay the plasma exchange, the mortality can be very high. Just to quote you, one of the renowned gynecologists from Kurnool, few years back was hospitalized somewhere in Hyderabad with a misdiagnosis of ITP. Next day morning she has seizures, and next day afternoon, before anybody could think of any other alternative diagnosis, she was lost. So such is the the patient's downhill course. So it is very, very essential. So again, DIC, the TTP, as I mentioned you earlier, all classical pentad is not required. Thrombocytopenia, evidence of microangiopathic hemolytic anemia, hemoglobin drop, reticulocytosis, cystocytes and peripheral smear is enough to suspect and start them on plasma exchange. And most important, you should have no possible clinical explanation for alternative possible diagnosis, right? So it's a mystery, but it has to be solved correctly. So identification of cystocytes. So again, there are various criterias. The criteria how to identify cystocytes on peripheral. So the diagnostic criteria is more than 1% cystocytes on peripheral smear is enough to call it as microangiopathic hemolytic anemia. And these are various pictures which pathologists can give us a valuable tool. Again, even here, most of the hematological conditions in ICU, it's like mathematics. You have algorithms, you have ready-made available calculators, you put the values and you can get up a reasonable score with a very good sensitivity, specificity. So for TTP, this is a plasmic score, the platelet lysis. So this is available online. You just put the values, clinical variables and lab values, and you will come up with a diagnostic score. Again, thrombotic microangiopathy is sometimes difficult. Many clinical mimickers like HUS, atypical HUS, DIC itself. So in pregnant ladies, other complications like hypersensitive disorders of pregnancy, HELP, preeclampsia, this should be kept in mind. So this next case, a 39-year lady from Karimnagar, who presents with symptomatic anemia, thrombocytopenia and leukopenia. You can see generalized weakness, fever, short duration, and she has profuse bleeding manifestations, menorrhagia, bleeding from gums, nose, ecchymotic patches all over the body. And if you look at her hemogram, hemogram is a vital tool for evaluation of all the hematological conditions. Just like an ECG for a cardiologist, endoscopies for gastroenterologist and imaging for neurologist, if the hemogram is the vital tool with which you can diagnose more than 95% of the hematological problems, not just hematological disorders. Look at her hemogram, hemoglobin is 7.3, WBC severe leukopenia, and you see neutrophils almost 0, and platelets are modestly suppressed, 40,000, but she has profuse bleeding manifestations. So we did coagulation profile PT APTT for such severe bleeding profile. There was the PT APTT was sky high, hypofibrinogenemia. So you can see bleeding disproportionate to the degree of thrombocytopenia. That was explainable by her active coagulopathy. So this is a active DIC, and these are abnormal cells on the peripheral smear, the largest cells. They are called as promyelocytes, and this is conclusive of one of the deadliest cancers on earth. They are called as acute promyelocytic leukemia. If not attended in time, delay of 1 to 2 days, mortality can be as high as 50%. That's even in the most developed parts of the world. And if we diagnose or suspect, even suspicion is enough to treat with, treatment is very simple, arsenic trioxide, readily available cheap chemotherapy drug, and supraphysiologic doses of vitamin A, all transretinoic acid. This can revert coagulopathy within 12 to 24 hours. The cure rates in 2023 for APML is 90 to 95%. So this is very important. So again, like the famous saying by William Osler, medicine is a science of uncertainty and an art of indefinite probability. So these differentials should always be thought of, and the take home message from this case here is urgent hematological referral for any patient presenting with pancytopenia in the ICU setting. If the patient has febrile neutropenia, the neutrophil count is less than 500, symptomatic severe anemia in failure, symptomatic severe thrombocytopenia, Possibility of DIC, abnormal peripheral smear like this case and the previous case, microangiopathy in TTP, blast suggestive of possible underlying hematological malignancy, possibility of severe aplastic anemia because of severe pancytopenia without organomegaly, lymphadenopathy, possibility of HLH very common in ICU setting, and metabolic emergencies associated with pancytopenia like hypercalcemia, hyperkalemia and evidence of hyperuricemia, AKI, suggestive of possible underlying hematological malignancy, right. So again, like the famous saying by Albert Einstein, if you can't explain it simply, you don't understand it well enough. These are simple problems. As I mentioned you earlier, hematology is just like mathematics, calculative, just little attention to the clinical presentation and emphasis on simple hemogram can give you clue in vast majority of the cases. This is a fourth case, 79-year gentleman, diabetic, hypertensive, huge comorbidity, stroke, admitted to ICU from a nursing facility for altered sensorium and hypotension for 2 days. Look at his hemogram. He has hypotension and scattered ecchymosis all over the body. Platelet is modestly low, 79,000. APTT 34 within the normal range, fibrinogen normal, PT normal, and he was found to have E. coli, UTI and sepsis outside. So diagnosis here. So again, based on his bleeding profile, you are contemplating whether to give or not platelet transfusions. Anybody? Platelet count is now 33,000. So when not to transfuse platelets? In ICU setting, this is a burning question. Transfusions may induce immune resistance, and transfusions for thrombocytopenias of sepsis without DIC, bleeding manifestations, you are contemplating an invasive procedure or patient is actively bleeding. These are the circumstances platelet transfusions are required, and the transfusion threshold for platelets in ICU setting is 10,000, right? And if the patient is bleeding, 20 to 30,000. You are anticipating any procedure, threshold of 50,000. But when there are possibilities of these catastrophic etiologies like thrombotic microangiopathy, APLA, HIT, DIC, ITP, platelet transfusions are contraindicated unless and until patient is having active bleed, ongoing CNS bleed, or you are anticipating any invasive procedure. So ICU thrombocytopenia and mortality, you can see, as I highlighted earlier, the mortality can be between 20 to 30% overall, and patients with thrombocytopenia almost 30 to 50%, without thrombocytopenia 10 to 20%. So almost double mortality, and again the same thing in a bar chart. And again you can see the thrombocytopenia and the relevant mortality at various time points. So very, very important, these are the causes of ICU thrombocytopenia. Sepsis commonest 40 to 60%, DIC 20 to 40%, medications third commonest 10 to 20%, and the rest all are not so common, and it can be multifactorial in half of the cases. So again, the impact of platelet transfusions in ICU, none of the papers across the literature has proven the benefit of platelet transfusions without any rationate, valid justification, right? So again, no study reported impact of platelet transfusion neither on the bleeding nor on improving the mortality of these patients. So I just wanted to highlight here that platelet transfusions are not the solution for patients presenting with thrombocytopenia in ICU. So the role of intensivist in patients with such patients is confirm the presence of thrombocytopenia, rule out pseudothrombocytopenia, various etiologies, assess the severity, rapidity, initiate workup for common causes, and then as required hematology consultation for evaluation, diagnosis of undefined cases, treatment of primary hematological disorders, and reassessment when diagnosis and treatment is unsatisfactory. So again, thrombocytopenia is scarier than it looks, like the Skylab of 1984s. Many of us seniors will remember, but yes, close team collaborative work can really help in these patients. So changing gears further, I quickly summarize. Do I have time? Another 10 minutes? 6 minutes, okay. So hematological patients coming to ICU. So many of you will think, why should, as an intensivist, we know about the hematological problems? Nowadays, the hematology, hemato-oncology patients, transplant patients going to ICU is exploding, which we have witnessed over last 12 years, because the available treatment modalities and the complications are increasing along with the increasing efficacy. So that's a must as a teamwork. So just for the students, 3 hematological malignancies, 3 most important: leukemia, lymphoma, myeloma. And the most common reason for hematology patients coming to ICU is neutropenic sepsis. So severe neutropenic sepsis can be about 10% of all hematological malignancies, mostly AML and allogenic stem cell transplant. This carries a very, very high mortality. Patient coming to ICU with neutropenic sepsis, mortality is 50% across the globe, both not just in developing nations like India, even in the developed nations. So again, the mortality predictors: respiratory failure, positive blood cultures, and MODS. So this is the causes of death, and you can see the commonest is the fungal infections and the bacterial infections. So most important is the culture positivity in Hem-Onc patients coming to ICU is just 10 to 20%. So 80% patients, despite having severe neutropenic sepsis, cultures are negative. You have to keep on escalating antibiotics to save these patients. So your antibiotic stewardship, your antibiotic policy doesn't come here. So when I was in Canada, the antibiotic policy, the only exception was Hemato-Oncology and bone marrow transplant. So I just wanted to highlight here. So again, bacterial infections common, 70 to 90%, fungal 5 to 20%, but fungal carries the more mortality. So again, I'm highlighting one case, 9-year girl, class 4 student. This was a story in 2016, symptomatic severe transfusion dependent anemia, and eventually she was diagnosed with pancytopenia, and to add to the nightmare, she grew MDR E. coli on the blood cultures. So again, you can see bone marrow showing confirming aplastic anemia, absolute neutrophil count less than 100, so confirming the diagnosis of very severe aplastic anemia, and at diagnosis MDR E. coli. I am sure as the eminent critical care specialist in this august audience, you will agree with me that MDR GNB sepsis ICU mortality for immunocompetent persons is 50 to 70%. For a girl with almost zero neutrophil count, it is a certified death, right? So this was severe aplastic anemia. How to treat this case? Again, you can see MDR E. coli. So this is our antibiogram from Yashoda Hospitals, Somajguda. 75% of our patients in Hemato-Oncology spectrum have MDR bugs. Of course, the antibiotic positivity was just 16%. So we stabilized her with granulocyte transfusions, aggressive antibiotics, with colistin and subsequently Zavicefta. We did emergency half mass transplant with father as a donor. Unfortunately, she rejected the graft. Second half, again the half mass transplant, these are the common complications. Graft rejection probability is 10%. Second consecutive half mass transplant with mother as a donor. Now she settled, recovered, of course post transplant little turbulent course. She was in ICU for almost 27 days with zero neutrophil counts, and almost 7 years post transplant completely cured and leading a normal life. This is India's first successful double half mass transplant with a duration of neutropenia 79 days with onboard de novo MDR GNB sepsis, right? So this is definitely a natu moment. I am the working face of my department, but there are hundreds of people, mostly our ICU team, who are the real warriors bringing out these success stories in the real life. So gearing further, this is second complication where hemato-oncology patients ends up in ICU, respiratory failure, the incidence is 15%, and again mortality. You see all the parameters, any patient coming to ICU from Hem-Onc or BMT spectrum, mortality is exceeding 50%. The most important for us, neuromuscular blockage and prone position early to safeguard these patients and to maintain the PA pressure less than 150. So she achieves, this lady AML high risk group achieves CR1, she is taken for haplotransplant, and post transplant she develops on day 12 such a picture. So, I'm sorry, this is rotating, so you can see this picture. So any guess? This already has highlighted. So it was just like a pulmonary edema, flash pulmonary edema. This is engraftment syndrome resolved with a short course of steroids. Subsequently, after 5 days of recovery, she started worsening ARDS, and this is her picture. Any clue? Anybody? Any thoughts? Look at the picture. So again, So our ICU team and my ICU colleagues are well versed with these complications. So we keep on sending CMV, sometimes twice, thrice week also. So CMV PCR 52,000. So this was the CMV pneumonitis. Again, if you see the literature evidence, the case fatality rate is 85%, right? So she required almost 17 days of mechanical ventilation, was treated with IV ganciclovir, IVIG, ventilatory support, recovered. This is the CMV monitoring. Just I am highlighting the with a fatality rate of 85% she recovered, and almost now 6 years post transplant. This is a high risk AML translocation 6-9, alive and doing well with a normal quality of life. Again, hats off to the teamwork, mostly by our ICU colleagues. So we need to think differently. These are atypical infections, think out of the box when hemato-oncology patient comes to your critical care unit. So again, this another case, 32-year male, relapsed refractory Hodgkin's, just recovering counts on day 11 post autologous transplant, resolving mucositis. He is already on ZNM colistin for ESBL, Klebsiella febrile neutropenia. At this point of time, he develops worsening respiratory distress, initially on BiPAP, subsequently requiring mechanical ventilation. Looking at the CT chest, any clues? So this is halo sign, right? So this is the X-ray, but then the CT is very clear halo and reverse halo sign. So aspergillosis, just 2 minutes, okay? So again, pulmonary nodule in aspergillosis. So fungi, mycosis have many faces, varied presentations, colitis, pneumonitis, rhinosinusitis. Keep a high index of suspicion for various fungal infection, and most of the patients are already on prophylactic azoles, mostly posaconazole. So again, despite breakthrough fungal infections are quite common, and it is worth, you can see the mortality in allotransplant is 70% with invasive mycosis. So of course there are various guidelines, hand hygiene very important, barrier precautions. Ideally, transplant patients should be kept in positive pressure ventilation, isolation rooms in the ICU, so which may not be feasible in most of the times. But this is the prerequisite for evaluating these patients on your every time you take a round with these patients. Look at the mouth, oral sores, auscultate the lung, check for the abdominal tenderness, and if the patient complains of perialveolar soreness, just visual examination without any intervention. So I will just conclude with this case. This is a ALL day 2 cyclophosphamide TBI based conditioning. He is almost now 9 years post transplant, and you can just see day 2 of transplant he has grade 2 mucositis, profound neutropenia, severe abdominal pain, hypotension. When I was carrying him to the ICU, I did the contrast CT abdomen. The radiologist called me that, telling in a fear that 20% of the ileal loops are not taking up the contrast. What will you do as an intensivist? Will you operate on this patient? Day 2 of transplant, the projected time to neutrophil recovery is more than 12 days now. So impossible in a country like India. So again, this is a neutropenic enterocolitis. We just conservative management, bowel rest, TP and round the clock upper and lower GI endoscopic decompression by flatus tube and NG tube, broad spectrum antibiotics, granulocytes, and he recovered. So surgical interventions, to do or not to do is not a choice. Most of the times, as much as possible, the surgical intervention should be avoided and antibiotics should be continued till neutrophil recovery or at least clinical resolution of the infections. Just 1 minute about the future of hemato-oncology and what as an intensivist you should be equipped with, because a lot of immunotherapies are coming, lot of novel therapies across oncologies are coming, and unless and until we acquaint ourselves with these kind of, so immunotherapy I will call it as a surgical strike against blood cancers. So we are in the era of precision oncology, so we should be aware of the cytokine release syndromes, because this next 5 years there will be flood of this CRS and ICANS neurotoxicity arising out of these newer hemato-oncology treatment options. So this is a severe aplastic anemia child, post half match transplant, again double half match transplant, he failed first half match transplant, persistent fever, ID workup negative, ferritin supra high. I am sure this H score all of you must be well versed with for HLH probability. So he has a high probability, so HLH was positive. So we started upfront targeted drug like ruxolitinib, and then this kind of immunosuppression led to more resurgence of more opportunistic infections like CMV, aspergillosis, tuberculosis. So great COVID teacher, blessing in disguise for hematology, because as an intensivist, you are now well versed with these CRS. You are trained to monitor IL-6, ferritin round the clock, and that's a blessing for us because most of our patients are going to come with such complications in the coming era. So we treated, and this was a rewarding case. I just wanted to highlight, after double half mass transplant, despite a deadly HLH, he recovered, and almost 1.5 year post transplant, not just recovered, he came up with the flying colors in his class 9 exam and doing well. So again, useful tips. Persistent fever in ICU, periodic ferritin is important, and hemophagocytosis, the term for its diagnosis is a misnomer. It's not mandatory to find hemophagocytosis for the diagnosis of HLH. So again, being a movie lover, a fantastic movie on this newer immunotherapies, Hemato-Oncology. So beautiful narration of CAR T-cell therapy. So just to conclude, these are the different newer modalities, newer milestones, records in India, across the globe we have achieved with the teamwork at Yashoda Hospitals. The first successful double half mass transplant, the youngest half mass transplant 9 months, the oldest half mass transplant 67 months, and so on and so forth. So blood disorders, blood cancers, contrary to our belief, this is the belief we have in our minds, right? It is hopeless, ugly and cruel, which is not true. The cure rates are 80 to 90%. And just before I conclude, this is a remark by my teacher, who is the father of hematology and bone marrow transplant in India, when I presented many of these cases through various forums in hemato-oncology and bone marrow transplant in the country and across the country. These unbelievable survival stories, this was the remark by Professor Maman Chandi at APBMT 2023, happened this year February in Cochin. These unbelievable survival stories reflect the quality of critical care at Yashoda Hospitals. So kudos to our critical care team. So the future in hemato-oncology is very exciting. We definitely need to change our approach to offer the best possible chance of cure and survival across these neglected blood disorders, hemato-oncology spectrum, as well as bone marrow transplant. And like the famous saying by Darwin, it is not the strongest of the species that survives, not the most intelligent one, but the one most responsive to change. Let us change, to work collaboratively together to bring out many such success stories. So again, I would like to take this opportunity, like the famous saying, coming together is beginning, keeping together is progress, working together is success. I would like to thank each one of the clinicians from our region for bringing out these success stories, and also like to take this opportunity to share my gratitude on the occasion of completion of 300 plus bone marrow transplant. And like the famous saying, when gratitude becomes an essential foundation in our lives, miracle starts appearing everywhere. And that's the impact of teamwork. Together everyone achieves more. And if I have seen further, I am not very old or not very great, but based on the experience of 11 years at Yashoda Hospitals, Somajiguda, I can say with confidence that if I have seen further, it is by standing on the shoulders of these giants. These are few faces, but there are many clinician colleagues and friends at Yashoda Somajiguda, Yashoda group of hospitals, who are the real heroes behind all these success stories. So with that, I would like to thank each one of you for the patient hearing, and I am sure there is no time for questions, but I will be happy if there are any questions at the end of this session. Thank you so much.